This last part of the discussion about COPD, we're going to talk about therapeutic options, medications, and also a little bit about exacerbations, although we're going to keep a primary care focus. One of the most important things, and I know we've talked about this already, is smoking cessation has the greatest capacity to influence the natural history of COPD. We always need to talk to patients about smoke cessation, regardless of whether they're there for COPD or whether they're there for a well exam or acute bronchitis. It doesn't really matter. We need to always discuss it with them. It's kind of odd, but if you don't discuss it with the patients, they go home thinking that it's okay. So when their wife or significant other asks them, did they talk to you about stopping smoking? They say, no, they didn't. So, well, you need to leave me alone about it. That's kind of the way it works. It's odd, but if you don't ask them to stop, then they just assume that that silence is you saying that everything's okay. There are lots of different things that you can use to help. I've had great success with Wellbutrin in combination with nicotine patches. So those are kind of my go-to, and it works really well for me. All COPD patients benefit from regular physical exercise. Everyone does. So make sure that you're talking with all your patients about it. And remember that they are, likely to self-limit their activity. And the less that they do, the less they're able to do. So I know you've heard me mention recliner, decliners, and that is absolutely true for COPD. Always think about with COPD is that, the appropriate medication is reducing the symptoms and hopefully reducing the frequency and severity of exacerbations, improving health status and exercise tolerance, and basically quality of life. But none of the medications that we use for COPD has really shown to modify the long-term decline in lung function. To stop smoking is really the only thing that we have that will do that. Don't forget about influenza. Don't forget about the pneumococcal vaccinations. Don't forget that there are now 2 that we use for the pneumococcal. So those are very important points. Smoke cessation, again, this is a little bit what I was talking about. Don't underestimate your power here, okay? Counseling delivered by healthcare professionals increases quit rates over self-initiated strategies. Even a brief 3-minute period of counseling to urge a smoker to quit results in smoking quit rates of 5 to 10%. So if all you do is mention it every time they come in, when they come in for their well exam, when they come in for their acute bronchitis, when they come in for their pneumonia, whatever they come in for, if you just say, hey, how are you doing with the smoking? Are you still thinking about quitting? Is there anything that I can do to help? And then don't forget about the nicotine replacement therapies and the different things that we have to help. Remember that there is a lot of physical dependence with tobacco. So, assist them in any way that you can. This is just one of the brief strategies to help patients to quit smoking. And you may have seen this in health promotion already, but you need to identify all tobacco users at every visit. If you're a non-smoker, you can kind of tell who smokes. I mean, you get up beside them to have a discussion with them when they're sitting on the exam table, and you need to listen to their lungs or look in their ears or whatever that you need to do, and it's pretty easy to pick up on the fact that they're smokers. But, another thing that you can do is have them fill out a questionnaire when they come in about tobacco use. I just think it's easy enough to pick up on it. Urge all tobacco users to quit, and that's what I talked about, regardless of why they're there. Bring it up, mention it. It's your job to do so. And then just talk to them about willingness to make a quit attempt. Have you ever tried to quit smoking? Have you ever thought about it? Is this something that you think you may want to try? There's lots of different medications that I can give you that may help, all those things. And then, if they decide that they do want to try to quit, then work with them on setting a quit date and then scheduling a follow-up contact. Therapeutic options, risk reduction. You know, we've already talked about the fact that the medications that we give really are only treating the symptoms. We're not affecting the disease. And we really don't have a way to do that. So when you have a disease like that, then you've got to focus on your risk reduction. And you need to encourage tobacco control policies. You need to talk to your patients about not smoking. You need to ask them what kind of exposures that they may have at work. You need to talk to parents about, you know, not exposing their children. You know, use anything that you can to kind of key them into the fact that they don't need to be doing this. Reduce or avoid indoor air pollution. You know, what kind of heating do they have, etc. COPD medications, this is just a brief list of the things that we're going to talk about. I'm sure you've seen these before. Your beta agonist, your anticholinergics, theophylline, inhaled corticosteroids. You've seen all of these before. So these are what we have to help. So bronchodilators are central to the symptomatic management of COPD. They're prescribed on an as-needed basis, like in Gold 1, or on a regular basis to prevent or reduce symptoms. We talk about the beta-2 agonist, anticholinergics. We talk a little bit about theophylline, although we're really getting away from using theophylline whenever we can. And we talk about combination therapy. So one of the things that we know is it's better to give a little bit of a beta agonist and a little bit of an anticholinergic than it is to kind of give the highest dose of a beta-2 before you move on to something else. So you have less problems with side effects if you kind of mix it up with combination therapy. And we don't do that often in any other kind of management, or, well, just not that often. I mean, usually we go to one drug and we max it out and we try to keep people on just one drug, like with cardiovascular disease. But it's kind of different here in that we're trying to treat a little bit of this kind of symptom and a little bit of this kind of symptom, so combination therapy works well. I'm just going to have you learn like the top choices, but there are lots of different ways that you can do these medications. These are guidelines, but you have to go with your patient's individual response. You know, how they do with side effects, how well it helps them, what medications they can afford, etc. All of those play into your decision-making process. So let's talk about inhaled corticosteroids. Regular treatment with inhaled corticosteroids improves symptoms, lung function, and quality of life, and reduces frequency of exacerbations. And that's one of the first things that they studied when they started using. I remember when we first started using Advair, a lot of us had been using it kind of off-label for COPD, and then they started doing some research using Advair and found that it reduced the frequency of exacerbations for COPD. Now, it's not for everyone, but if the FEV1 is less than 60% predicted, then you want to add an inhaled corticosteroid. Now, don't forget that with COPD, you never want to use an inhaled corticosteroid just by itself. You need that bronchodilator. Inhaled corticosteroid therapy is associated with increased risk of pneumonia, so you want to make sure that you get your pneumonia vaccinations in as you start this kind of therapy. And if you do start it and decide to stop it, you need to taper it, because it can lead to exacerbations in some patients. So just be aware of that. So combination therapy, I talked about one type of combination therapy, which is, using your beta-2 agonist, but also using an anticholinergic and having that to be scheduled, and using that kind of combination. But another thing that they talk about with combination therapy is like an inhaled corticosteroid combined with a long-acting beta-2, so something like an Advair. Combination therapy is associated with increased risk of pneumonia, and we talked about that, and that has to do with the inhaled corticosteroid. Now, also addition of a long-acting beta-2 inhaled steroid with like an anticholinergic also provides additional benefits. And as far as I know, they haven't really figured out exactly why putting them together increases. They're kind of synergistic in that when they're given together, they work better. And I mean, just kind of thinking about the pathophysiology, I'm thinking that, well, when you use the beta-2, it's going to open you up and you're actually going to be able to take, a deeper breath and get more of the inhaled corticosteroid in. But, that's just the nursing side of me trying to think through things. But so you're going to see these combinations, they tend to be a little bit more expensive, but they do work better. So if your patient can afford them, then you want to go with this type of combination. Just a quick point about oral or inhaled corticosteroids. We've talked about that. A monotherapy not recommended. If you get to the point where your patient needs to be on an oral corticosteroid, they need to be seeing a specialist. And I would say that for any disease process where you have them on oral corticosteroids. To me, that's not nurse practitioner management. There may be some out there doing it, but there are so many potential adverse effects with oral corticosteroids that I really think that's a specialist call. So I would recommend that you refer for that. There are also other medications that you can use to reduce exacerbations if the patient has an FEV1 less than 50% of predicted, chronic bronchitis and frequent exacerbations. And I'm really hoping that you have also referred those patients already to a pulmonologist in your area. Okay, non-pharmacologic management of stable COPD, smoke cessation. I mean, really can't say that enough. And if you need to give them medication to help with that, that's fine. At this point with patient group A, you also may feel like that they need a PRN beta-2 agonist. Don't forget about physical activity. Don't forget about your vaccinations. And the same with group B, C, and D, which corresponds with goal 2, 3, and 4. Never forget about smoke cessation. Always, don't ever forget that. Just ask every single time. And if they get upset about it, just say, listen, I wouldn't be doing my job if I didn't ask you to do this. So, I've got to do this. It's part of what I'm supposed to do. It's my job to help you and to talk about this with you. And they usually are okay with it once you say, I've got to do it. It's my job. You want to think about pulmonary rehab for, goal 2, 3, or 4. Don't forget about physical activity, and then don't forget about your vaccinations. They say depending on local guidelines, and I really am not sure what that means, because these are people most likely over the age of 65 that you're going to need to give these vaccinations to. Okay, pharmacologic therapy. And this is where I said that I would tell you how we're going to do the exam. And basically how that we're going to do the exam is we're going to say patient A is gold 1, patient B is gold 2, patient C is gold 3, and patient D is gold 4. And you're only going to need to know what the recommended first choice is. In real life, of course, you need to know your alternative choices and other possible treatments, but for the exam, you need to know that gold 1 is a short-acting anticholinergic or short-acting beta agonist. Gold 2 is a long-acting anticholinergic, long-acting beta agonist. Gold 3, we're getting to people who have an FEV1 less than 60%, so we're going to add the inhaled corticosteroid. At this point, we're probably also thinking about referral as nurse practitioners, and then gold 4, which is D, then inhaled corticosteroid, long-acting beta agonist, and or long-acting anticholinergic. So, kind of depending on how your patient responds, you'll adjust your medications, but don't forget to make the referral when the referral needs to be made. All right, other pharmacologic treatments. I've talked to you about the vaccines already. Don't forget your influenza. Don't forget your pneumococcal. I mean, these are patients that are extremely high risk, and you really need to protect them. So the pneumococcal, they do kind of clarify this a little bit. Recommended for COPD patients 65 and older, which is something that I just mentioned, and for COPD patients younger than 65 with an FEV1 less than 40% predicted. So they're in pretty significant poor shape and less than 40% predicted. So they're probably going to be people that you've moved on to a specialist at that particular point. The use of antibiotics other than for treating infectious exacerbations of COPD and other bacterial infections is not currently indicated. This is always a tough call. There are exacerbations, and we're going to talk about this a little bit more, that need an antibiotic. The majority do not need an antibiotic. And we're going to talk about this a little bit more, but you always think that you need to throw an antibiotic at everything, and it doesn't necessarily help. All right, we talked about the alpha-1 antitrypsin augmentation therapy. So the alpha-1 antitrypsin, not recommended for patients with COPD that's unrelated to genetic deficiency. And again, don't forget who to test for that. They're usually Caucasian and under the age of 45 and family history of COPD. Mucolytics, patients with viscous sputum may benefit from mucolytics. Overall benefits are very small. Most of the research on those say that really it's the water that you're giving them that helps thin the secretions, not necessarily the mucolytics. So, I mean, if the patient really feels like it's helping them a lot, if you give them some guaifenesin, then, I'm okay with you giving them guaifenesin. But really, it's not going to help that much. When you give them the guaifenesin, you need to tell them to drink lots and lots and lots of water, and they will feel like it's working because the water's actually what's working. But I'm fine if you give them that. I mean, it's up to you. Cough suppressants, not recommended. We do not recommend, cough, I keep saying this through all of this, is a defense mechanism. Don't suppress it. Vasodilators, again, contraindicated in stable COPD, and this is something that's going to go on to specialists, so I don't want to spend a lot of time discussing it. All COPD patients benefit from exercise training, improvements in exercise tolerance. It also improves the symptoms of dyspnea and fatigue. An effective pulmonary rehab program is 6 weeks. I've talked with some people who say that their program is as much as 18 weeks. The more effective the results, the longer the program. Now, if you can get the person to exercise at home, even after the pulmonary rehab, then they retain their health status even after hospitalization. So that's extremely important to get them back feeling strong again. So oxygen therapy is really the only thing I'm going to talk about on this slide. we still want to give oxygen PRN, and I'm not sure exactly why, because the research really hasn't shown that it's that helpful. Long-term administration of oxygen greater than 15 hours per day to patients with chronic respiratory failure has been shown to increase survival in patients with severe resting hypoxemia. So if you're going to do oxygen therapy, or your pulmonologist has prescribed oxygen therapy for your particular patient, then ask them how often that they're using it, because sometimes they think if they use it a lot during the day that they'll get dependent on it. And I'm not sure exactly where all that comes from, but if they can use it greater than 15 hours per day, it has a significant benefit to them. Other treatment, we don't, in the past, haven't talked that much about palliative care, end of life, and hospice care, but we're really starting to talk more about it. And especially as we go through the gerontology, geriatric information, we learn a lot more about palliative care and hospice care and how to handle the end of life. But you need to talk with your advanced COPD patients about end of life care and advanced care planning so that they have the opportunity to make informed decisions. I mean, we've all been nurses in the hospital. We've all seen those patients who we put on the vent and never come back off again. So we need to know what their wishes are ahead of time before that big exacerbation happens. And, it's important to talk with these patients about these kinds of things because, they're also grieving and also maybe suffering from some depression. So having these kind of conversations, I mean, if they can't talk to you about it, who are they going to talk to about it? Key points. This is just what we've talked about. Identification and reduction of exposure to risk factors. We can't really treat it. We can help the symptoms. So the best thing that we can do is help prevent it. Do an assessment of symptoms, airflow limitation, future risk of exacerbation. That's the grid that we talked about. That's how you kind of make your decision about your management strategy. So you take all of that into consideration. All COPD patients benefit from rehab, pulmonary rehab if you have it available, and discussion of remaining active. Remember that the medications that we give are used to reduce symptoms, reduce frequency and severity of exacerbations, that's our inhaled corticosteroids, and to improve the health status and exercise tolerance and their basic quality of life. All right, we're going to switch gears here for the rest of the presentation. There's not that many more slides left, so hang in there. We're going to talk about exacerbations, and if you really don't know what that is, it's basically like a person who has asthma who has an asthma attack. And this is an exacerbation or an attack of COPD. It's an acute event characterized by worsening of the patient's respiratory symptoms, and it's much beyond the normal day-to-day variations. And lots of times we need to change the medicines to help them get through this acute phase. The most common cause of COPD exacerbations, just like what causes asthma attacks, viral upper respiratory tract infections, not bacterial, but viral. Diagnosis relies on the clinical presentation of the patient complaining of an acute change of symptoms. So they are much short of breath and they come to see you because they're different than they were. And that's one of the things that we always ask, this has been going on with you for a long time. So, what made you come in today? What's changed? What's different? And that's when they come in to see you. And the goal of the treatment is to minimize the impact of the exacerbation. And then if we don't have them on that inhaled corticosteroid, do everything that we can to prevent those exacerbations. So treat the one we have and realize that the one we have is a precursor to let us know that they're at risk for others. So take all of that into consideration. So how to manage, it's actually not that much different than managing an asthma exacerbation. You get a short-acting inhaled beta-2 agonist, or with or without a short-acting anticholinergic. And so that's the treatment. We're going back to the rescue inhalers because we're in a difficult situation. They're almost always going to get systemic corticosteroids. And don't worry, this isn't a long-term thing. This is very short-term. We're talking 5 days and then maybe a short taper after that. They may or may not get an antibiotic, and that's going to depend on a few things that we're going to talk about. But if we give them the corticosteroids, even if they've been on and inhaled, they may just need another boost to kind of get that inflammation down. Then it's going to help improve the lung function as well as the oxygen. And hopefully we can keep them out of the hospital, and that's what we want to do. COPD exacerbations can often be prevented. You know, let's do the vaccinations. Let's talk to them about exercising, eating right, staying healthy, avoiding people who, you know, have viruses, good hand washing, all those kinds of things. And then also give them some oral corticosteroids to start taking at the very first sign that they're moving into an exacerbation. So let's jump on this fast and quick. Prevent what we can, and then jump on quick what we can't. So the consequences of COPD exacerbations. And when we talk about this, please don't think that everybody who gets an exacerbation ends up in the hospital. The majority of the time they don't. The majority of the time we can handle this. We can get them started on some corticosteroids and we can help things. But if we don't do that, then exacerbations can have a very negative impact on quality of life. And what they do is they impact symptoms and lung function, but they also accelerate the lung function decline, which means that if someone goes into the hospital and they get ventilated and then they come back out, their post-hospitalization spirometry never really recovers back up to the pre-hospitalization spirometry. So we have to prevent these, because once they have these, especially if it's to the point that they're hospitalized, then their spirometry takes a big nosedive and it never comes back up to where it was before. It may improve and they get out of the hospital, but it never goes back to the way it was initially. So assessments during acute exacerbation, you know, how much of this that you do, and I'm glad they say the ABG measurement is in the hospital, because we're not going to do that in the office. I mean, whether or not we do a chest x-ray really depends on whether or not we're pretty sure that this is an exacerbation for COPD or whether we think something else is playing in. And that's, you know, most of the time going to be some type of cardiac problem. So whether we need to rule that in or rule that out, or whether the patient's sick enough to go onto the ER or to, you know, be seen by a pulmonologist right away, all of that's going to kind of play into how they look. Purulent sputum during an exacerbation is an indication to begin empirical antibiotic treatment. It's really hard during an exacerbation to really know whether or not to start an antibiotic. That's always a tough thing. We're going to talk about what the indications are for that in just a minute. Spirometry not recommended during an exacerbation. You know, you can't have them doing spirometry when they're having trouble getting their breath. And I think that's another thing that people don't think about with asthma, is that they think, oh, well, we'll have them do pulmonary function tests. Well, you can't have someone do pulmonary function test who isn't getting enough air to really, you know, carry on a conversation, and their respiratory rate's, you know, 32. Well, what are spirometry gonna, what is it gonna tell you? It's gonna tell you that things are bad, and you already know that. So treatment of exacerbation. You know, when they come in, we're going to do a pulse ox. And we definitely want that pulse ox to be between 88 and 92. You know, every patient's going to be a little bit different. I mean, some patients you may know they walk around with 89 all the time, so it's not a big change for them. But if this is a huge change for them, then that's important for you to pick up on. You're going to use your short-acting beta-2 agonist, maybe a short-acting anticholinergic as well, and then you're going to give them systemic corticosteroids, and we talked about that. It's going to be a short dose, 40 milligrams per day for 5 days is recommended. So if you don't do more than 5 days, you probably don't have to taper, especially if they're already doing inhaled corticosteroids as well. So that's your treatment. Now, whether or not you give an antibiotic, we're going to talk about how you make that decision. But these are the 3 that you definitely want to pay attention to. So treatment options. Antibiotics should be given to patients with 3 cardinal symptoms: increased dyspnea, increased sputum volume, and increased sputum purulence. And of course, you know, those who require mechanical ventilation, which is out of our scope of practice for sure, but it's always hard. I mean, it's easy on an exam. You know, if I said, well, you know, you don't give an antibiotic, they did not have increased dyspnea, did not have increased volume, and did not have increased sputum purulence. If I said like no change in sputum and no increased dyspnea, then you'd automatically know that I'm thinking, okay, they don't need an antibiotic. So on an exam, it's pretty easy to pick up on. In real life, I think it's just really hard sometimes to make this call. You don't want to always give them antibiotics because you don't want to, you know, get to the point where you don't have an antibiotic that they are not resistant to. And these we know are people that we're going to probably have to give frequent antibiotics to, so we've got to be very kind of stingy in when we give them out and not just give them out when they're not needed as well. So, you know, you're going to give them the corticosteroids, see how they do. I'd probably give them a day of the 40 milligrams, see how they do. If they didn't have these symptoms, and if they were doing a whole lot better, try to get by without the antibiotic. If they weren't a whole lot better and I called them the next morning and they still weren't better, or they talked about increased dyspnea or anything else going on, then I probably want to go ahead and add this antibiotic, because remember, we are trying to keep them out of the hospital, trying to keep them from being ventilated. So in real life, honestly, this is a really hard call to make. Indications for hospital admission, and I said that, you know, deciding whether or not to do an antibiotic is a hard call to make. Well, it's also sometimes a hard call to make when you need an immediate referral. And I think your nursing is going to really kick in and help you here, because if their COPD is already severe, you know, that you don't have a lot of leeway to go downward. If you start initial medical management, start them on their corticosteroids, start them on an antibiotic, and they're not responding, then that's an issue for you. If they have other really serious comorbidities, they're probably more likely that they're going to end up in the hospital. If they're older, if they have insufficient home support, all of those indicate the fact that you're more likely to need a referral. Manage comorbidities. This we kind of talked about when we first started talking about COPD, and we're back to that. Remember, I said that there's hardly anybody who's going to walk into your office and COPD is going to be the only problem that they have. You have to take into consideration your other comorbidities. Sometimes it'll affect your COPD treatment, most of the time not. Of course, airway, breathing, circulation, right? I mean, we've got to keep the patient breathing regardless of what else is going on. So sometimes they're going to need those corticosteroids, even though it may make something else a whole lot worse, like their diabetes. I mean, all those decisions have to be made. So the biggest, probably most worrisome comorbidity that we have to deal with is cardiovascular disease. And we're talking about, heart disease, heart failure, atrial fib, hypertension. All of those things play into COPD. And then, benefits of the cardioselective beta blocker treatment in heart failure outweigh potential risk even in patients with severe COPD. We're not going to be making those decisions, thank goodness. Someone else on a higher pay grade is going to make those decisions for us. And last but not least, and I don't think I even have to tell nurses that you need to provide holistic care to your patients. I mean, we know that. It's just a given for us. But think about your osteoporosis, especially if you have someone on corticosteroid or your pulmonologist does, you're still going to be managing the side effects of those kinds of things. So osteoporosis, also think about your age group, who's more likely to have COPD, who's more likely to be at risk. I always think about anxiety, depression. We talked about this a little bit earlier, but not being able to breathe is pretty anxiety inducing. Not being able to do the things that you really want to do can cause significant depression. Don't forget about the lung cancer. The hemoptysis, the change in sputum for somebody who's already coughing, who's noticing a difference, it's very worrisome. Respiratory infections are going to be more frequent. They're probably going to be more serious. So sometimes, when you might give a macrolide to someone else, you may have to give a fluoroquinolone to someone with COPD. Metabolic syndrome and diabetes, more frequent. And again, this all sometimes plays into the medications and the lack of physical activity. All of it kind of goes in together. So everything that you ever wanted to know about COPD.